So first, my disclosure. And I will talk about the epidemiology of GI cancer and risk factors, the data from the Middle East, and the availability of drugs and financial burden, and the challenges that we are facing in the cancer care. The Middle East is not one country. They are a mix of several countries of the high, middle, and low-income nations. There are large differences in the population size, in the wealth, health expenditures, and the availability of quality of treatments. Now it reached around 390 million and expected in 2040 to reach more than 500 million. Age distribution varies widely with the major differences in percentage of young and old. And for example, the data from Jordan and Egypt, percentage of less than 20 years up to 50%, and more than 50 years up to 10 to 15% only. And this can explain why the Middle East has a lower incidence of cancer compared to the Western population. This is data came from the Middle East Cancer Consortium, which includes 5 categories: the Jordan, the Izmir, Turkey, Israel, either the Arab and Jews, and the US SEER data. And you can see the lowest incidence of cancer among all in the Middle East in men and women. Going more to the wider, the Eastern Mediterranean group, and this in collaboration with IARC published last year in Cancer Epidemiology, you can see that in the males, concentrating in GI cancer, if you take Egypt, for example, in the red, you can see number 1 is liver cancer, and this predominance for the hepatitis B. If you take the, for example, in Lebanon, and this is the yellow, you can see the higher incidence will be in the prostate cancer. And what is important in GI cancer, you can see in Jordan in the green, the higher incidence in the colorectal cancer presenting the highest among the Middle East countries, reaching around 20 per 100,000. And also the gastric cancer, you can see it higher in Islamic Republic of Iran and Afghanistan, representing the around 10 to 12 per 100,000. And this reflects also in the mortality. You can see it in the red in Egypt, it's due to liver cancer mainly. And also the other countries like Afghanistan and Iran, gastric cancer number 1 mortality. In females, the predominant, the green is the colorectal cancer, either in the incidence and the mortality, except the mortality in Egypt predominant with the liver cancer. For the GI cancer in Lebanon per se, there is a trend toward an increase in the incidence of all GI cancer, with significant rise of the annual % change in certain types of cancer as respected by the p-value, as you can see here. And this also a trend and increasing in all types of cancer in the GI, which is the contrary of the US data, as you can see here, they published recently with a trend of decrease in the incidence and mortality. Also, comparing the colorectal cancer in the Middle East, you can see that the Jordan, the highest, as we said before. Coming after the Jordan, we have Lebanon, then the Tunisia, representing the 3 highest colorectal cancer. But if you compare it with the Western population, again, we are much less than the Western population and the SEER data. Also, on the gastric cancer, the incidence is under the 7 to 8 per 100,000. Compared to the Western population, it is much less than the Western population. Talking about something important, which is the proportion attributable risk factors and how this risk factor will affect the developing of the cancer in the future. In the GI cancer, we have a preventable diseases and factors because 50% attributable to the H. pylori in our population and around 24% to smoking. And in our studies in the population, we have 80% among the population H. pylori positivity. So targeting H. pylori may prevent this type of cancer. In the liver cancer, the BMI, and as you can see, the steatohepatitis, one of the causes besides smoking. In pancreatic cancer, BMI and smoking. Colorectal, we have BMI, low physical activity, and low adherence to Mediterranean diet. These are the major factors. And in the gastroesophageal, the low physical activity, and also in esophageal and gastric cardia, the high BMI is the main risk factor. Moving from the Lebanon to the Eastern Mediterranean region, and this is recent data submitted with the work with the IARC, you can see in males, the most important in male is the diet and the smoking, coming later infection, mainly the H. pylori, and later on we have the physical activity and BMI, with least is alcohol consumption in the region. In females, the most important is the physical activity, BMI, and infection, specifically in the gastric and the HPV and cervical cancer. These are the main targetable and preventable factors in females in the region. Moving to the data from the Middle East, talking about the publication and how the participation in the clinical trial, and this is from recent published data, less than 50% of cancer patients are aware about or trust any clinical trials in the region. And you can see here the number of the population compared the number of the studies. And if you take the number of cancer open studies per 100 capita, you can see among the region, we have one of the highest in Lebanon compared to the low number of population, which is estimated to be in the range of 5 to 5.5 million. The status of radiation therapy in the region, and included, this is in the low and middle income countries, there is encountered about 139 countries fall under this category. And all the Middle East, except Lebanon, is excluded because they have the required radiation, which encountered as 500 new cases per unit, and this encountered in the range of per year. And since we have around 10,000 new cases per year of cancer, so 50% of cancer cases will need radiation therapy. So this accounts for 5,000 cases. So we have 10 radiation units in Lebanon, and this is enough for our population. But here in the other countries in the Middle East, we have 40% deficiency, and this expected to have deficiency not only in the units, but only in the radiation oncologist, in the physicist, and also in the technologist. These are all deficient and expected to, required by 2020, we need to cover this gap in the region. There is also important to know the new technology, specifically the PET scans, and how to use these techniques in diagnostic and therapeutic. And you can see among the region, there are no PET scans in several countries. And in our region, if you estimate the PET scan per million people, the highest will be in Lebanon, 2.2 per million. And how to use this, and this from recent publication, from using gallium PET scan in neuroendocrine tumor. You can see in collaboration with University of Liverpool, we have 445 patients between 2010-15. From Lebanon, we have among them 126 patients. So we are using these modern techniques, and therapeutically we apply the treatment with the radioactive peptides, also using the gallium in neuroendocrine tumors. Specifically, For the other tests in the molecular testing colorectal cancer, and this data from the Middle East also representing the KRAS in around 28% and BRAF in 2.5%, and also represent how we can use this information, specifically in the right-sided tumor, predominant, we have the BRAF mutation with the MSI high, with KRAS wild type, or CIMP with this type, and also the correlation of the KRAS mutation with outcomes, specifically in late stage 4 cancer, and the impact on survival. Also, many molecular labs do the MSI testing in the region, and this is the MSI high in around 11% in the region. What about the availability of the drugs in the region and compare it to the Western population? If you take this comparison, you have to take into account the use of foreign exchange rate versus the use of purchasing power parity. And the important is the use of the purchasing power parity, because this explains the real income of the individuals within certain nations. So if you take the use foreign exchange rate, we'll find the highest pricing of the drug, the cost in the United States and in the Western population, while it is lowest in the India and China. But if you take the real one, which is the using purchasing power parity, you can see the highest cost of the drug will be in the low and the middle income countries. So this is very important, and you can see that the pricing of the drugs, specifically the targeted therapy in colorectal cancer, it follows the income of the, and varies according to the income of these countries. It is not unified in all countries. And this is recently published about the financial burden of cancer drug in Lebanon. You can see there is exponential increase in the burden of the cost of the cancer chemotherapy from 2008 to 16. And this represents around 59% of all cancer cost for the Ministry of Public Health, and the cancer load varying from 40 to 50%. But recently, and since 2013, the Ministry of Public Health succeeded in reduction of the main targeted therapy by 30 to 40% pricing. And this is allowed to cover most of the population in the Lebanon for the recent drug. What are the challenges of the Middle East? The incidence and mortality of GI cancer in the Middle East are still rising, while in the Middle East they are still rising, while they are trending down in the USA. Middle East countries comprise both the high and low risk population, because the number of the low risk are increasing to the high risk, with GI cancer with increasing trend in the low risk, so that there is a need to apply or implement both the primary and secondary prevention program in the region. Most of the modern and laboratory techniques are available, but you need to unify that this availability will be confined more to the high and middle income countries. There is a great variation in pricing of anti-cancer drugs between East and West. And tackling lifestyle is important as to avoid many risk factors that will be the key in the prevention. And differences in population size, economic variation, dysfunctioning primary health care systems, and cultural beliefs may all hinder best cancer care in the Middle East. I will stop here. Thank you.